Today, my talk is called Drug Use in Our Communities, a Health Issue, Not a Moral Issue. And I have several ideas that I wanted to share with you. Most importantly is that we're one big family. I know sometimes that we have divisions between us, but I think when the going gets tough, we put our hearts in the right place. I want to talk about the idea of two-eyed seeing. You know, all of us have, well, not all of us, but most of us have two eyes. And we see from one point of view and then the other point of view, and we join them together into a single vision. And for most of us as Kaimu, we look backward at our ancestors and our way of being and knowing and the knowledge that was handed to us, maybe from people who maybe no longer even are alive. But we also look forward and we have modern issues, things that we're trying to learn about, things that we never dreamed we would ever have to deal with, but we're dealing with them. So we look back and we look forward at the same time. So we look forward and back at the same time. And I think actually it's pretty cool. Two-eyed seeing is a very simple idea that we see with one eye of Western knowledge and the other eye with indigenous knowledge, and they unite in a single vision. And I think for those of us who have or who value both those perspectives, they can marry into a single vision that's extremely helpful. Two-eyed seeing also is about the ability to look in the mirror or to look at yourself, to look outwards and look inwards at once. And I always remember having a teacher, a doctor who was a teacher, say to me that I had to sleep at night with the decisions that I made that were affecting people's lives. And we're the same. We have to sleep at night with the decisions we make to help or to not help, or to be with our family or not be with our family, to do the best we can under a lot of pressures. The idea, though, is to try and find some balance, to try and fit all of the things that we want to do and need to do together at once. So for us, it's to be connected to each other, to be connected to our families, but also to do our work, to be good parents or grandparents, but also to be good kids or good siblings, and to do a wide range of things, not just one thing. Two-eyed seeing is also acknowledging our past. 1492, the year that Native Americans discovered Columbus lost at sea, is one perspective that's maybe ours more than the dominant cultures. This is a painting from Hawaii. I was in Hawaii until this morning. I just came from Hawaii today. I was meeting with some Native Hawaiian doctors. The Native Hawaiians are just about to have their sovereignty or their indigeneity, their original people's status recognized by the American government. And one of the things that they did that's related to us is there was a captain named James Cook. Captain James Cook traveled through New Zealand, Polynesia, Antarctica, up into North America and our coast. He made 3 different trips. And on his 3rd trip, he stopped in Hawaii again for the 3rd time. His 3rd trip, his 3rd time in Hawaii. And he kidnapped an ali'i, an elder, a kapuna, royalty, kidnapped them, and then the Native Hawaiians killed him. And on board that ship was a midshipman named George Vancouver. And George Vancouver was famous for returning to Hawaii and bringing cows. So the people of Hawaii said, oh, we know who Vancouver was. He brought cows to Hawaii. But also Captain Vancouver came to our coast. 1792, this is a drawing. One of his artists drew a village on Cortes Island. I think it's important for us to remember these pasts and remember that we're connected to the events before this. This is Charlie Adams, or Atum, my great-grandfather, my dad's grandfather. In 1862, he was blinded in a smallpox epidemic that ran from California to Alaska. And in 1930, he was hospitalized for dementia, and that's when this photo was taken. He was blind. He's alive in this photo. He's blind, and some blind people, they don't open their eyes because they don't use their eyes. And I think it's really important for us to remember that, and that he had many, many children. Sammy, Maggie Wilson, Palanick or Veronica Charlie, Celestine Edwards, my dad's mom, Losa or Rosie, Ida Timothy, Agnes Paul, Lily Louie. These are. Oh, and he married Kokasuk Sarah John or Sarah Johnson, who became Sarah Williams much later in life. These are many family names reminding us that we are really connected to each other. And I think sometimes we focus a bit on the differences between us and not on the similarities between us and our families. And Elsie, I have to speak to you about Charlie Adams and his connection to our family. I know we've been talking about it. We have to talk again. So what we also have in common is that we want to protect our people. We want to protect the new generation. We want to protect ourselves. We don't want to lose family members for nothing, even if they're troubled by addiction. British Columbia declared a public health emergency just this year in response to a massive increase in overdose deaths in the past 2 years, but particularly this year, since January. Since January, over 400 people have overdosed and died in British Columbia. That doesn't include overdosed and survived. That's overdosed and died. That's an unbelievable number. It's the leading cause of death of British Columbians at the moment, even more than motor vehicle injuries. So people are dying from pills more than they are from car accidents. And this just shows the difference. It's kind of a heat map. This is a map from 2015, and you see the colors are very light. And you see in 2016, the darker the color, the more overdose deaths there were in that region. But we can prevent drug overdoses, and it can be fairly straightforward sometimes. So one of the main reasons that we're having overdose deaths is a new kind of fentanyl coming from China. This new fentanyl is a type of opioid, a type of morphine drug. It's a downer as in it slows you. It also controls pain, but it has this terrible side effect of addiction, overdose, and death. So people take it sometimes for pain. Sometimes people abuse it to get high, and they have these unfortunate consequences of overdose, addiction, and death. But this new type of fentanyl is 10 times stronger than the old type of fentanyl, and it just takes a few grains to overdose. A little tiny amount, like a few grains of salt. So the BC coroner has some warnings. We do not want drug users thinking that if they can just avoid fentanyl, they're not at risk, as this is very much not the case. Because we're hearing about fentanyl, but there are a number of overdose deaths that are not fentanyl related. Fentanyl was detected in a third of the overdose deaths, but 2/3 of the time there was no fentanyl. So that means other opioids like heroin and morphine are still causing deaths. So the most important thing is to support people with drug issues. We know that the majority of people who are overdosing are people who habitually use drugs or use opioids. So we should be supporting them. It can be a matter of life or death, rather than judging them, rather than pushing them away from help or assistance. So what we're finding is that people who have drug issues don't ask for help because they're used to being treated badly, and when they don't ask for help, they die. So we can tell people who have drug issues, who have an illness, that they're valuable, and we don't shame them. We say we can help them. Of course, recognizing that addiction is often a lifelong affliction that comes and goes. It peaks and then it wanes. People with addiction often fight with it for their entire lives. They get better, they get worse, they get better, they get worse. And you can try and help them at the same time as not getting involved in their cycle of up and down, and you riding up and down with them and being overly committed to their health, much more committed to their health, or that you're committed to their health more so than they are. So the bottom line is, when people struggle with addictions, they need to feel safe with us and that they're valued. And that's the most important gift that we can give them so that they can survive another day. It's the idea of a lateral kindness. You've all heard of lateral violence. To me, lateral violence is we've learned that when someone steps on us, we bite back like a snake. If you step on a snake, it'll bite you. And many of us have learned to be like that. We're tough because we're from a tough world. Someone kicks me, I will kick them twice, or I'll kick them back. So that kind of lateral violence we can normalize, but it's actually sometimes not helpful. In fact, often it's not helpful. And so there's this idea of lateral kindness, where we're kind to each other because we can afford to be. We don't always have to bite. We don't always think someone's going to step on us. And so ditto with our care with people with addictions. We can be kind to them rather than mean. I want to introduce this idea of harm reduction. Harm reduction focuses on learning and talking about how to keep ourselves, our families, and our friends safe. So rather than valuing abstinence, where we say no one should use anything, we say, well, some people have always used something or other. They may continue to do that, and I'm okay with that. I will still interact with them, and they deserve my help. So we seek to reduce harms rather than demand abstinence. And we try and prevent their death rather than saying, oh, go and die because you're an addict. We can initiate conversations where we feel uncomfortable, where they feel uncomfortable, because it's life-saving. Certainly in speaking to patients, I know from speaking to patients, you can feel a bit odd talking to them about their issue because it's not your issue. You make them the focus of attention, and your needs and ideas are put aside. That can feel uncomfortable, but it is really important to try that. We can also prevent overdose deaths in another way, a very simple way. We can be prepared. People will overdose in this community. They have, and they will again, and they will in this generation, and they will in the next generation. It's kind of like kids falling and breaking their arm. It's highly predictable. It just occurs. It just happens. My son broke his collarbone just last week. Kids fall down, just like some people use, and some people use too much. So if an overdose is going to happen, we should be prepared. So what can we do? Well, we can learn the signs of overdose, and I think we're going to review that with our lovely nurse. And we can have something in our homes called naloxone. You can actually have it in your home and be prepared to administer it. Giving naloxone is not brain surgery. It's actually fairly easy to do, and we can kind of talk about how that's administered. We can be brave, and we can talk to each other about being prepared for overdose. And we can practice lateral kindness and harm reduction in order to save lives. Here's a take-home naloxone kit, something I suggest those of you who know someone at risk have in your homes. So taking care of each other is not just for medical professionals. I think most of you out there know who's at risk, particularly those who are close family members of those who are at risk. You know when they're at risk, and so you can know to have this kind of kit in your home. So around naloxone, just a couple of points. Naloxone is not prescribed anymore. You can get it over the counter, or you can have it handed to you by by the clinic, right? We can talk about how that works. We'll talk about how that works. It's free. It's an injectable medication in that you administer it with a needle. Some people are afraid of needles, but I think of needles as being like knives. They just have a sharp point. They're not necessarily dirty. You can always have a clean knife. There can be clean needles. Most people think of needles as being always dirty. They're not always. They come sterilized. And you can learn to use them fairly easily, just like using a knife. And naloxone reverses the effects of an overdose from an opioid drug. I've given them many, many times. I used to work in the downtown east side. In fact, where's my Auntie Corrine? Auntie Corrine and I were going for lunch one day when someone overdosed in our waiting room, and I made you wait while I administered some naloxone on the floor and trying to rouse that person and get them to emerge. Because the naloxone wears off, and that person can overdose again in several minutes. So you need to get them to emerge once you've given the naloxone and sit with them. So Tla'amin, we're very, very lucky. Tla'amin has an amazing health team. Actually, this health team is the envy of many, many, many communities. Many communities would love to have the kind of developed team that we have here. You can count on them, and you can ask them to be involved or more involved. You can ask them for help. You can ask them to improve the quality of their service. All of that is fair. And certainly you can ask me to come and help you if there are things that we want to talk about. Again, we're family. What happens to you happens to me. What happens to them happens to us. None of us deserve to lose family members. So I do urge all of you to do what you can in order to quell this state of emergency. We won't be able to turn these numbers of deaths around without some planning and some action. Great. So I'll hold for. Shall we do questions now? No, we'll swap out, and then we'll do questions afterwards. Thanks, everyone.